this evening session of ISOT CPC webinar series. I am Dr. Jigar Shumari, Council Member of ISOT and one of the program in charge for this academic initiative. So today's case title is Biopsy Treasure Hunt, uncovering the uncommon cause behind a common post-transplant biopsy. So for this, before we begin, it is my pleasure to honor to introduce our esteemed panel for today's session. So the case presentation will be done by Dr. Divya Prabha. She is DNB nephrology resident from the Department of Nephrology at Max Super Specialty Hospital, New Delhi. Pathology expert would be Dr. Anisha Manocha. She is the associate consultant again from Max Super Specialty Hospital, Saket, New Delhi. And nephrology panelist will be Dr. Kulwant Singh. Is the principal consultant from Department of Nephrology at Max Super Specialty Hospital, New Delhi. And today's moderation will be done by Dr. Radhika Krishna Patil, madam. She is the vice president of ISOT as well as the CPC program in charge. And it will be done by myself also. And today's special acknowledgement would be that we are privileged to have the presence of Dr. Arpita Ray Chaudhary. She is the president of ISOT, and Dr. Manish Banwani, honorable secretary of ISOT. And we thank them for their constant support and leadership in advancing this academic excellence in the transplantation. So, and again, this webinar is not only on Zoom, but it will be also ISOT YouTube channel. And we encourage all the attendees to actively engage through the question answer in the box and share their query so that we can have discussion on that. So with that, let's begin our academic journey. And now invite Dr. Divya Prabha and Dr. Kulwan for the today's case presentation. I think we should, yes.
Good evening, everyone. I am Dr. Divya, DRNB nephrology resident from Max Super Specialty Hospital, New Delhi, and I'm going to present one interesting case for the CPC. This is case of a 69-year-old male who is diabetic since last 25 years, hypertensive since last 15 years, and was diagnosed with chronic kidney disease in 2011, and it was a biopsy-proven DKD, which gradually progressed to ESKD in 2015, and later he was initiated on hemodialysis. In 2022, at the age of 66 years, he underwent deceased donor kidney transplant. That was a B2B transplant. CDC crossmatch was negative. PRA pre-transplant was 0% for both HLA class 1 and 2. Induction given was ATG, and he was maintained on tacrolimus, MMF, and steroid. Although post-transplant, his graft function was slow and a DTPA scan was done, which was suggestive of ATN. And at discharge, his creatinine was 1.4. Coming to the post-transplant events, in May 2022, patient developed intractable diarrhea. He was evaluated extensively, but only positive finding that time was H. pylori on endoscopy and was treated for 14 days. In July 2022, he again developed GI symptoms in the form of acute gastroenteritis, was found to have cryptosporidium, was treated with nitazoxanide. At this time, at discharge, again, his creatinine was 1.1. In October 2022, that was 6 months post-transplant, on routine workup, we found that he had proteinuria, 1+ protein in urine microscopy, and it was quantified, and UACR was 1.5 grams. Hence, he was started on ARBs, tablet telmisartan 20 mg. But his proteinuria progressively increased from 1.5 grams to 2.4 grams. Hence, we added dapagliflozin, but the proteinuria kept on increasing. So we had to do a kidney biopsy for the patient. The kidney biopsy showed focal segmental glomerulosclerosis and diffuse ATN and was advised for EM. In this chart, we can see that there is a progressive increase in the proteinuria from 1.5 gram to 4 grams. Hence, fenrenon was also added. And meanwhile, we received the report of electron microscopy, which was also consistent with the features of primary FSGS. Since the proteinuria did not decrease, we gave the patient rituximab 500 mg, 2 doses, 1 week apart. And post that, we saw some improvement from 3.9 grams, it reduced to 2.7 grams. In March 2023, that was 11 months post-transplant, patient again developed GI symptoms in the form of intermittent loose stools, weight loss, and his USCR that time was 3.1. He was evaluated for cause of infections, which were negative. CMV, EBV were negative. So MMF was changed to azathioprine, thinking it to be one of the cause. Volume depletion and weight loss was significant, hence SGLT2 inhibitor was stopped. PET scan was normal. Myeloma panel was also negative. In May 2023, patient was evaluated again. He presented with pedal edema and his UACR increased to 3.5 grams. We did 5 sessions of plasma exchange, following which he showed some improvement and proteinuria decreased. In October 2023, patient presented with accelerated hypertension and pedal edema. Again, his proteinuria was rising. So his antiproteinurics were escalated. And he was given plasma exchange 5 sessions along with 1 dose of rituximab, thinking it to be a relapse of FSGS, which showed some improvement in the subsequent months, and his antiproteinurics were continued. In February 2024, patient had boil on his right finger, which was an infective. Cultures showed pseudomonas. Incision and drainage was done along with IV antibiotics. Azathioprine was reduced in view of leukopenia. Rest of the immunosuppressions were continued. Telmisartan was decreased. Fenrenon and dapagliflozin were stopped. In the index admission in March 2024, patient got admitted with chief complaints of progressive bilateral lower limb swelling for last 10 days, fever with chills, 1 episode which was 4 days back, and 1 episode of black tarry stool, shortness of breath and decreased urine output for 3 to 4 days. On evaluation, he had pancytopenia. His creatinine was 7.2. Procalcitonin was also high, which was 88. Peripheral smear was consistent with findings of pancytopenia. LDH was slightly high, that was 352. Urine routine microscopy showed 8 to 10 pus cells, and UACR this time was 6.6 grams. With this history and relevant investigation, we made a provisional diagnosis of sepsis secondary to urosepsis pyelonephritis, pancytopenia related to sepsis or would be drug-induced, acute on chronic graft dysfunction, UGI bleed related to thrombocytopenia, fluid overload leading to respiratory distress. Patient was started on empirical antibiotics, azathioprine and telmisartan were stopped, and other immunosuppressions were optimized. In view of anuria, fluid overload, and acidosis, patient was initiated on hemodialysis. We did a further workup, and CT scan showed nodular thickening of the stomach wall. Graft kidneys were normal. Peripancreatic haziness was seen. Hence, amylase lipase was sent, but they were within normal limit. PET scan was also normal. However, upper GI endoscopy showed esophageal candidiasis, gastritis, and polyp. Polyp was biopsied, but it was negative for dysplasia. CMV EBV was negative. Urine culture was also sterile. This is USG graph Doppler, which showed increased echogenicity in the transplant kidney with attenuated CMD and increased RI with absent diastolic flow. At this stage, we did a graft kidney biopsy. So before we go into the findings of biopsy, let's reiterate the story. 69-year-old male, diabetic, DKD, hypertensive, underwent a deceased donor kidney transplant in April 2022, had intermittent GI issues, were treated with antibiotics and optimization of immunosuppression, had increasing proteinuria, was found to have primary FSGS, treated with rituximab and plasma exchange. In this current admission, had sepsis, pancytopenia, graft dysfunction requiring hemodialysis. To evaluate for the cause of graft dysfunction, biopsy was done. And Dr. Anisha will further guide us on the biopsy findings.
So we received a biopsy with a total of 6 glomeruli, of which 2 were sclerosed. IFTA was around 25 to 30%, and there was no large artery. So before we start with the glomeruli, let's just quickly look at the tubular interstitium. The tubules are showing moderate injury with fine and coarse cytoplasmic vacuolation and flattening of the lining epithelium with loss of brush border. But there's no significant tubulitis, interstitial inflammation, or peritubular capillaritis. If we look at the glomeruli appear enlarged, cellular, and show a lobular accentuation. On a high power view, we can see that there is increased mesangial and endocapillary hypercellularity, and mostly the cells which are occluding the capillary lumina appear to be either monocytes, macrophages, or endothelial cells. Why? Because they have a larger nucleus and abundant cytoplasm. The glomerular basement membrane shows some evidence of GBM duplication. But the prominent finding here is the presence of this hyaline-like material or the hyaline thrombi, which are seen occluding the capillary lumina. If we see the PAS stain, we can again see areas of increased cellularity, GBM duplication. But when we look at these hyaline-like material, they appear slightly PAS negative. On the silver stain also, these thrombi appear negative for silver stain. But on the empty stain, they appear bright red in color. Congo red stain was also done, and that was negative. On immunohistochemistry, C4D deposits were seen along the GBM. That usually happens whenever there is any amount of GBM remodeling that is taking place. But the peritubular capillaries did not show any staining for C4D. SV40 immune stain was also negative, ruling out a BK virus nephropathy. So to summarize the LM findings, the glomeruli showed increased cellularity with focal GBM duplication, making it an MPGN pattern of injury. There were prominent hyaline thrombi which were occluding the capillary lumina. The tubular interstitium showed a moderate degree of acute tubular injury, but there was no significant tubulitis, interstitial inflammation, or peritubular capillaritis. C4D immune stain was negative. So with this background, I want to ask the audience what their differential diagnoses are based on the biopsy findings.
So we can have the inputs from the audience.
So
So Dr.
this
Kulu,
webinar portal's audience can't speak here, sir. Basically, audience can
yes.
only
So
listen.
Dr. Kulwan, yes. So Dr. Kulwan, from your
Right,
end,
sir.
before doing this second biopsy, what was your mind for this biopsy findings? Or it is something different what you achieved during this biopsy?
Sir, actually, in the first time we did the biopsy, we got the findings of FSGS. When the second time there was increase in proteinuria, we thought that it is relapse of FSGS because it is very common, and we treated with the plasmapheresis again. But this time, when he came to us, we thought that this is sepsis because procal was high, and there was some pus cells in the urine. So even after CT scan and urine culture, we could not actually zero in on the diagnosis. So we planned to go for a biopsy. Still, the diagnosis, still our provisionals were ATN related to some sepsis. Secondly, we thought that as there was thrombocytopenia, hemoglobin may be low due to there was upper GI bleed and there was increased LDH. Those histocytes were normal. Still, we thought one possibility of TMA. We were not thinking of any other glomerular disease at this stage before knowing the biopsy results.
Okay. So, Dr. Kulwan, from your side, any further discussion on this case?
Sir, I think we can move ahead with Dr. Anisha's presentation.
Okay. Dr. Anisha.
Yes, Himanshu.
Meanwhile, there could be a question and answer in the chat box that we can deal later on.
Okay, sir. Yeah, Himanshu ji, please proceed.
Yes, ma'am.
Congo red stain was also done and that was negative. On immunohistochemistry, C4D deposits were seen along the GBM. That usually happens whenever there is any amount of GBM remodeling that is taking place. But the peritubular capillaries did not show any staining for C4D. SV40 immune stain was also negative, ruling out a BK virus nephropathy. So to summarize the LM findings, the glomeruli showed increased cellularity with focal GBM duplication, making it an MPGN pattern of injury. There were prominent hyaline thrombi which were occluding the capillary lumina. The tubular interstitium showed a moderate degree of acute tubular injury, but there was no significant tubulitis, interstitial inflammation, or peritubular capillaritis. C4D immune stain was negative. So with this background, I want to ask the audience what their differential diagnoses are based on the So whenever in a
Okay.
post-transplant biopsy, we are seeing increased cellularity of the glomeruli with GBM duplication. The first thing we must rule out is an ABMR. While ABMR is a possibility, there are certain points against an ABMR. First thing is there was no other evidence of microvascular injury like peritubular capillaritis, and C4D was also negative. So with this, let's keep ABMR a little lower down on the differential list. So if we have an MPGN pattern of injury, the next question that arises is that how do we approach this MPGN pattern of injury? For that, we need to look at the IF findings. So if you're getting positivity for both immunoglobulins and complements, that makes it an immune complex mediated MPGN. And the causes for that include either a monoclonal gammopathy, infections, autoimmune diseases, or it could be idiopathic. If the IF is complement dominant, it could either be a C3GN or a C4GN. And if it is completely negative for all immunoglobulins and complements, we are dealing with the chronic TMA. So let's look at the IF studies in this case. The IF showed a diffuse, granular, peripheral and mesangial staining for IgG, C3 and C1q, with IgG showing the dominant staining. IgM and IgA were negative. But when we looked at the light chains, there was restriction for kappa and lambda was negative. Even on immunohistochemistry, the thrombi were positive for kappa stain and they were completely negative for lambda. So when we go back to this chart, we see that our case falls under this category of an immune complex mediated MPGN due to an underlying monoclonal gammopathy. So the next thing is to look at the various causes of MPGN. While there are various causes, we need to focus on the ones with an underlying monoclonal gammopathy. And the differentials include a PGNMID, cryoglobulinemia, immunotactoid, fibrillary, monoclonal gammopathy associated C3GN, and a monoclonal gammopathy associated TMA. So for a fibrillary GN, usually an MPGN pattern is quite rare and only about 10 to 15% of fibrillary GN is associated with monoclonality. So this puts it again lower down on the differential list. In a C3 GN, we would not have gotten dominant staining for IgG and TMA is usually negative on IF. So the first three, that is PGNMID, cryo and immunotactoid, become the main differentials in this case. So with that background, the biopsy report was signed out as an MPGN pattern of injury with IgG kappa deposits. And EM studies were advised to exclude first a deposit glomerulopathy with substructure, such as a cryoglobulinemia or immunotactoid GN. And if substructure was not seen, then these findings could represent a PGNMID. And features of a rejection were not seen. Divya will discuss the course further.
So with this biopsy finding in mind, a few additional investigations were sent. C3, C4 were normal. Cryoglobulin screening was negative. In the myeloma panel, SPEP showed M spike. SFLC ratio was 2.32. Immunofixation electrophoresis showed M spike in IgG kappa. After hematology opinion, bone marrow aspiration and biopsy was done, which showed trilineage hematopoiesis with 7% plasma cells. FISH was negative. Patient was discharged on intermittent hemodialysis. Tacrolimus and prednisolone were continued, and azathioprine was stopped. After making a diagnosis of monoclonal gammopathy of renal significance, it was suggested to start him on bortezomib and dexamethasone. At this point, we should look for the electron microscopy finding as well, which will be discussed by Dr. Anisha.
So before we go on to the electron microscopy findings in this case, let's just discuss the EM approach to MGRS associated lesions. So for that, we need to look at the deposits, and the deposits can be of two types, either non-organized or organized. In non-organized deposits, there are basically three differentials. First is an LCDD, second is a PGNMID, and third is a C3GN associated with monoclonal gammopathy. If the deposits are organized deposits can be of three types. First is fibrils, second is microtubules, or we can have crystals or inclusions. If we are seeing fibrils, there are two differentials. First is amyloidosis and second is a fibrillary GN, and both of these will have randomly arranged fibrils. In amyloidosis, the fibrils will have a diameter of 7 to 15 nanometer, whereas in fibrillary GN, the diameter will be 15 to 30 nanometers. If we see microtubules, again, we have two differentials. First is immunotactoid and second is cryoglobulinemia. In immunotactoid, we usually see long parallelly arranged microtubules with a diameter of 10 to 90 nanometer. And in cryoglobulinemia, we see short paired microtubules with a diameter of 25 to 35 nanometers. LCPT and crystal storing histiocytosis are also rare conditions. So in this case, what did we see? We saw subepithelial and subendothelial as well as mesangial electron dense deposits, which on higher power showed substructure. Here we can see long parallelly arranged microtubules with a diameter of 16 to 25 nanometer. And thus on the EM, the diagnosis of immunotactoid glomerulopathy was suggested. So with this, the final diagnosis on biopsy became immunotactoid glomerulopathy.
So the final diagnosis of post-transplant MGRS, which is secondary to de novo immunotactoid glomerulonephritis in a case of deceased donor kidney transplant recipient presenting as acute graft dysfunction in the background of de novo FSGS and diabetic kidney disease. So we started the patient of bortezomib dexamethasone, which was given for 8 weeks. However, there were no renal recovery. Patient remained anuric. Thus, it was stopped. And he was initiated back on hemodialysis. TAC and MMF were stopped and he was continued on prednisolone. So these are few critical points which needs to be discussed here. Coming to the take-home messages, post-transplant glomerulonephritis is a major cause of graft dysfunction, prevalence being 3 to 20%. The most common cause of post-transplant glomerulonephritis are IgA nephropathy, FSGS, membranous nephropathy, and MPGN. In post-transplant FSGS, it is seen that increased levels of permeability factors in pre-transplant period can predict post-transplant recurrence, but role of preemptive or pre-transplant plasmapheresis or rituximab is still debatable. Recurrence of MGRS had been reported, but de novo MGRS in the form of immunotactoid GN has been rarely reported. The treatment of immunotactoid glomerulonephritis depends on treating the underlying cause. So we have to be mindful of the rare conditions, especially in post-transplant kidney biopsies. and we should always send a thank you.
So I think it was very nice discussion related to having primary FSGS. Generally, when we have already one pathology with renal biopsy proven situation, we generally don't look for any other thing. So, and this is really an important thing that we need to have IF. Without that, sometimes we miss some important pathology that again need to be reviewed. So, Dr. Kulwan, for you, in any post-transplant proteinuria, as this case started, what's your belief? How you do the management, and what is your threshold to go for graft biopsy with this situation?
So generally in all the graft biopsies, like every nephrologist is practicing, we generally keep a very low threshold for graft kidney biopsy, not like native kidney biopsies. So especially in the scenario, if you know that your basic disease is suppose primary FSGS or I say C3GN, even in the early period, even if the proteinuria is mild or is increasing, say in the first week only, we suspect of these relapse or recurrence and we go for kidney biopsies. Particularly in this case, who presented around 6 to 7 months, when there are other causes of proteinuria also, but in such scenario, when the proteinuria is increasing very rapidly or the proteinuria is very massive, and despite your renal functions are normal, then definitely we suspect some glomerular pathology and we go for kidney biopsy. In this patient also, we counseled for kidney biopsy, but as he was related to a medical field. So he sorted for multiple second and third opinions and then agreed for graft kidney biopsy.
Okay. Now, how would you differentiate between the recurrent FSGS and de novo FSGS clinically and histopathologically? Clinically, if you can comment, Dr. Kulwan Singh, any
So clinically,
clinical.
if first is the timeline, the recurrence generally occurs very early. Some of these studies have shown that it have occurred within first few days only, whereas de novo occurs late. And especially when we do the kidney biopsy in the early period, we generally sometimes don't see anything on the light microscopy in the early period because the sclerosis and fibrosis, everything will take time. So the clinching point for the diagnosis in these cases will be EM only, where they will find some defacement in the food processes. Whereas in de novo, which occurs in the late period, we can have, like in this case, we can have the findings on LM also. Secondly, if we have the availability of permeability factors, which are potentially toxic to the podocytes, the levels of these are on a higher side in the cases of recurrent FSGS.
Okay, so your comment on the availability of permeability factor levels?
Sir, currently there are many factors which are available, but practically or commercially they are not available where we can get them easily. Like in our hospital or in the labs in Northern India, we are not getting the SUPAR or urinary levels done. So we are just relying on our clinical findings that if a proteinuria is coming in the early period or a patient who is having the history of FSGS earlier biopsy proven, then we suspect that this is a recurrence of primary FSGS.
Okay. Dr. Anisha and Dr. Radhika, madam, what's your view on the differentiation of these two pathology histopathologically?
Yeah. Yes. Dr. Anisha?
First, of course, when we are getting the form, we must look at the history. Like Dr. Kulwan said, first, it's very important when you're evaluating such a case to look how much time it has been since the transplant. Usually, a de novo is at least more than 1 year, whereas a recurrent can occur within days, or sometimes it's been said that even within hours, and it presents with a nephrotic syndrome. A de novo will usually have varying degrees of proteinuria. But when it comes to the histopathology, what they say is that a recurrent FSGS usually has a histomorphology similar to the FSGS pattern in the native kidney biopsy. Whereas if it is a de novo FSGS, the most common pattern noted is an FSGS NOS followed by a perihilar FSGS. Other patterns have been reported, but they are much rarer. And other than that, a de novo FSGS usually uh, has been attributed to various causes, one of which is a CNI toxicity, and the other cause can be a hyperfiltration injury. Of course, there are other causes like hypertension, obesity, viral infections, etc., but these are the two main causes. So, the other thing that we should look for are whether the biopsy is showing any other features of a CNI toxicity. Uh, when we come to the EM findings, because a recurrent FSGS is the presentation is a complete nephrotic syndrome, the food process effacement is usually more diffuse, whereas in a de novo, you can have varying degrees of food process effacement, sometimes less than 50% also. Other than that, if it is just a histologic picture and we don't have a lot of clinical history, it can be very difficult to say that this is recurrent or this is a de novo.
Yes, absolutely correct. And like we have seen, LM and IF is also very important. IF is also very important when the transplant is of long duration. So in this case, if EM would not have been there, I think the diagnosis would have been restricted to just PG and MID. So Dr. Anisha, what is your opinion? And Kulwant sir, like as a nephrologist, when would you like to advise EM as it is a costly test for patients in our country? So how like it will be utilized and how it is useful. So when the nephrologist should poke and take another core, or with the block only we can LM block only we can do the test.
There is again an institutional practice. Some institutes at present are sending every biopsy for EM also. But at our institute, as you said, we want to make the things cost effective. So we generally advise for EM when our nepropathologist, Dr. Anisha, discuss with us that we have to go for EM for further diagnosis. Then we send the same block for electron microscopy. So, like in this case, where there was we were in a dilemma whether this is cryo, whether this is immunotactoid or PGNMID. So, EM studies were very much required to make the correct diagnosis.
Yes.
I want to add, ma'am, on with this, with these biopsy findings, there were very prominent. Of course, it was an MPGN pattern. It was showing one immunoglobulin. It was showing both complements, and it was showing restriction for a light chain. But there were prominent hyaline thrombi which were present within the capillary lumina. So with this picture, there are three differentials that I discussed. Of course, PG and MID is one of them, but hyaline thrombi are also very prominently seen in
Right.
cryoglobulinemia, and rarely they have been reported in immunotactoid
Mm.
also. So these three became the LM differentials for this case. Now, to differentiate these LM differentials, EM becomes very important. If we have non-organized deposits, it's a PGNMID. If we are seeing organized deposits, it's either a cryo or an immunotactoid. Cryo will have short paired microtubules of 25 to 35 nanometer, whereas immunotactoid will have long microtubules of 10 to 90 nanometer. So that is one thing. Second is regarding when to send for EM. 2019 BANF has given a lot of literature this time regarding EM post-transplant. What they've said is, according to their paper, that any transplant less than 3 months, um, which has come for cause of graft dysfunction, should have a core for EM, and any transplant more than 6 months, whatever the cause may be, should be sent for EM.
Yes.
So that is their recommendation. But ideally, this is the bare minimum. But ideally, they've said that all post-transplant biopsies should be sent for EM, and this should especially be done when the suspicion is either of a recurrent or a de novo glomerulonephritis or an ABMR. Because on EM, we look for very early signs of transplant glomerulopathy. The CG1A lesions get picked up on EM. Also, now in this paper, they have given proper definitions regarding transplant glomerulopathy and PTC multilayering, and both these can only be seen on EM. So, in all these conditions, EM becomes very important.
Thank you.
Also,
Radhika, may I?
Yes, ma'am. Good evening,
Yes,
ma'am.
madam.
Good
Good evening,
evening,
madam.
good evening. I
Arpita
was
madam, good
listening
evening.
to a nice case and a nice differential elaboration by the younger people. I was really enjoying the case. So, uh, one thing to share with Jigar, the
Yes, madam.
very important clinical things that we have seen with recurrence of FSGS, which tells us you have to have very strong suspicion as well. Uh, One of our patient went anuric on day 4 or 5, and after that he didn't open in next few weeks. So we were not able to look at even the proteinuria window because we didn't look for the urine. He normally made urine after transplant, and first 4 days we didn't feel any necessity to send urine. But after the fourth day, there is a sudden drop of urine output. And as you know, that after excluding all factors, as we in the process of workup, as we sent for a biopsy, there we found an ATN. And anuric ATN not improving anyway, every possible thing is being done. And we, after the third biopsy, as recommended by KDIGO and every rational person would do, the repeat biopsy, we were not doing every 7 days, but we at least did at 10 days. In the third biopsy, we got really FSGS there. So that then looking back to the history of the patient, we thought that FSGS could have been a probability, and it was FSGS, after which he opened in the month of 6 or 7, when continuous plasmapheresis were being given. I think after 39 or 40 plasmapheresis sessions, he opened up. So it was a teaching to us that going to the native kidney disease history very accurately, to have a strong suspicion about FSGS, and whenever you have that, you send the first urine available for you to record for next first week, so that we can keep on chasing the urine for recurrence. So that is a very important issue regarding sending the EM core. It is rational that we should send uh, keep a core for EM as well, even if we do not send it considering the cost effectivity, that as soon as we require it, particularly after post 6 months biopsy, we may always require it to exclude the uh, chronic active ABMR, light microscopic, and changes suggested, and we need to confirm it by EM. So it's rightly spoken that post 6 months biopsy, definitely keep a core for EM so that you can make it. Thank you. Nice discussion. Keep
Thank
on
you, ma'am.
going. We have a regional conference and
Oh,
meeting
oh, oh.
today,
Oh.
so I might leave. Please go on.
Grateful for
Thank
your
you, madam. You
insightful
brought
knowledge
an
for
important
sharing,
insight.
madam.
Yes, madam. Thank you, madam. So, Dr. Kulwan, related to use of bortezomib, with the situation of the patient where already the patient on tacrolimus-based immunosuppression, uh, isn't it something like using bortezomib would be with a significant immunosuppression?
Yes, sir. Rightly said, sir. There is always a risk of over immunosuppression in our kidney transplant patients. But at present, we are in a gray area. We don't have any consensus guidelines either from the International Myeloma Working Committee or KDIGO. What should be our strategy for the patients? But definitely, patients with MGRS have a high risk of progression to multiple myeloma. And secondly, patients with MGRS have a high risk to progression to kidney failure also. So treatment should be started seeing the patient's performance status. So what we did in this patient was, normally how we treat MGRS is that we are giving a cytotoxic based regime, which is known as CyBO-D, which comprises of cytotoxic therapy like cyclophosphamide, bortezomib, and dexamethasone, plus minus daratumumab. So, but in this patient, we only went with the bortezomib and dexamethasone regime, and cyclophosphamide was not used. In our patient, as there was pancytopenia, so one of the drugs like azathioprine was already stopped. But it has been recommended that if we are using cytotoxic based regime, we should stop our anti-metabolites like MMF or azathioprine. Tacrolimus, we try to keep on a lower side. Suppose the levels at this juncture is around 4 to 6 nanogram per ml. We try to keep it around 4 nanogram per ml. And steroids were continued as it is. And whenever we are treating the patient with bortezomib or any other cytotoxic therapy, it is advisable to restart them on PCP prophylaxis and antiviral like acyclovir.
So, is there any predictor for the response in post-transplant MGRS?
Sir, the predictors are, first is the what is the level of creatinine at the presentation, how rapidly the deterioration of the graft was there, what was the level of M spike and SFLC ratios. In older patients, patient with lambda restriction, the response or the progression is higher, and the response rate with the therapies is lower. This case was immunotactoid. Actually, immunotactoid de novo is very rarely reported. So the studies are not clear what will be the response rates and what will be the predictors. What I have highlighted is a general predictors for the MGRS.
I think this condition must be underdiagnosed. The reason would be the biopsy, pre-biopsy clinical suspicion wouldn't be that high, particularly this type of situation where already the primary FSGS was the diagnosis. And later on also, one of the reason infection was there, with which we were thinking about sepsis, and post sepsis ATN was also the consideration. So in that situation, is there any data available throughout the world, any related to post-transplant MGRS?
Yes, sir. So there are anecdotal studies where they have regional studies where they have shown that the MGRS has high risk of progression to graft failure. If you see the MGUS, in MGUS, the transformation to multiple myeloma is less than 1% per year. But in MGRS, it can be as high as 15 to 18%. So definitely at any juncture, definitely we should justify the patient life and kidney survivability. But the treatment of MGRS should be done for both hematological and renal response. So in this patient, sir, there was 3 biopsies done. Luckily, every biopsy EM was also done. The native biopsy was diabetic kidney disease. In second biopsy, we never suspected, but it turned out to be de novo FSGS. In third biopsy, it turned out to be de novo immunotactoid. And when the once patient was admitted in between 1 year back, again myeloma panel was done as shown by Dr. Divya, and it was negative. Maybe we are thinking that second time when we did the plasmapheresis, maybe if we have done the biopsy, which we don't do because we suspect that it must be a recurrence of FSGS, maybe we would have picked the MGRS earlier.
Okay. Radhika madam, from your end, any question?
Nothing, sir. I think if just Kulwan sir guide us like the short
So,
presentation.
sir, if you allow me, I have a small PPT for residents just to cover de novo GN and MGRS, how we treat.
Yes.
If we can play that.
After that,
If
maybe.
you allow me to share my screen.
Yes. Himanshu ji, kindly do the needful. No?
Himanshu ji, can I share my screen?
Sir, I have started sharing if you don't mind.
Right, sir. So I'll tell you when to do the next.
Yes.
Okay, can we have a screen presentation mode? Okay. So when we talk of recurrent and de novo GN after kidney transplantation, so post-transplant glomerulopathy, glomerulonephritis is a major cause of graft dysfunction, and it is a third leading cause of graft loss at 10 years. Reported prevalence of when we pool the various GN is around 3 to 20%, but we don't know the true prevalence because it is likely underestimated because we lack the protocols for protocol biopsies. We don't have standardized screening methods, and we generally sometimes don't know about the primary cause of end-stage kidney disease, as highlighted by Dr. Arpita ma'am also. Next. Next slide.
I think
so. When we talk of recurrent diseases, these are the 4 recurrent diseases which are most common: IgA nephropathy, FSGS, membranous GN, and MPGN. So IgA, FSGS generally recur in around 20 to 50% patients. Membranous is generally on a lower side, 10 to 20% patient. MPGN depend on the type of MPGN. If it is a complement-based MPGN, the recurrence can be as high as 80%. And if it is non-complement based, recurrence is around 20%. But whenever the disease occurs, the graft loss can be as high as 50 to 60%. Next. So when we see the recurrence of a disease, apart from FSGS and MGN, the first therapy is antiproteinuric therapy. In FSGS, I will further discuss in other slides. In MGN, what we do is we level in the recurrent, we try to see the levels of anti-PLA2R. If the levels are very high, we first go for the immunological remission by giving rituximab. Next. So in recurrent primary FSGS, up to 1 in 3 patients with primary FSGS, which means around 30%, will experience disease recurrence after kidney transplantation. And management remains challenging with the treatment strategies, which are guided predominantly by small case series only. Next. So this thing is very clear that in recurrence, in the patients who have post-transplant recurrence, there is increased level of pre-transplant predictors, which are known as our permeability factors. So there are various permeability factors which are being studied in research purpose, like serum SUPAR, urine SUPAR, anti-CD40 autoantibodies, urine apolipoprotein A1B, A180, cardiotrophin like cytokines, and angiotensin receptor 2 type 1 antibodies. Next. But a practical approach in the management of FSGS recurrence post-transplantation should initially include, first is optimization of antiproteinuric therapy, then initiation of plasmapheresis. The patients who are on mTOR-based regime should be again shifted back to CNI-based regime if possible, and B-cell depletion in the form of rituximab, which can be adjunctive treatment or to be used in the resistant cases. There is currently insufficient data to suggest that doing preemptive plasmapheresis or rituximab to decrease that permeability factors will reduce the risk of disease recurrence post-transplant. Next. The role of newer therapies like immunoadsorption and novel options like ofatumumab and co-stimulated blockage like abatacept to prevent disease recurrence or to treat the recurrence is still debatable. Next. So when we talk of de novo GN occurs at a lower frequency or incidence as compared to recurrent diseases. So they are further divided into the GN which are commonly recurring like IgA nephropathy, FSGS, membranous GN, and MPGN. So the point to learn over here is that in the patients with de novo GN and membranous GN, normally what happens is that whenever there is a recurrence of membranous, there will be IgG4 staining like they are in the native kidneys. But in de novo membranous GN, the staining is generally not IgG4, it is IgG1 or IgG3. Next. So after commonly recurring, there are rarely recurring de novo GN like minimal change GN, collapsing GN, fibrillary, and immunotactoid. There are very few case reports on de novo immunotactoid GN. One case report showed that it was related to CMV infection, and after the treatment of CMV, there was reversible association with the treatment. Next. And few of the systemic diseases like can present as de novo GN, like in patients with Alport syndrome. Whenever they are transplanted, they can develop anti-GBM disease, though the de novo, this type of disease is very rare. In very few patients this occur. Or post-immune GN can also present as a systemic de novo GN. Next. Next. So now coming to the prevalence of MGRS, it has been seen that incidence of PTLD in kidney transplant patient is 1 to 4%. And amongst these PTLD, plasma cell dyscrasia is less than 4%. So absolute incidence of plasma cell dyscrasia is actually very low, less than 1%. But still, if we compare them to the normal population, it is 80% higher risk than the general population. Next. 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 So now coming to the de novo immunotactoid GN, it can present as proteinuria, which is often nephrotic range, hematuria, microscopic, hypertension, and graft dysfunction. For diagnosis, we generally require our EM study, where we can see the tubules of ranging between 10 to 90 nanometers. On IF, the IgG dominant staining is there, which can be diffuse and granular. And IgA and IgM are generally negative, and there is a monoclonal restriction of either kappa or lambda. If you see the time of onset, recurrent immunotactoid GN generally occurs soon after the transplantation, whereas de novo, like in this case, appears later, sometimes years after the transplantation. Next. So whenever we talk of any MGRS, or if I have highlighted like in this case, we always look at the clonality of the disease in the MGRS. So if the diseases are monoclonal, next. So in that cases, generally there is hematological malignancies, and clone-dependent therapies generally help in the treatment of these hematological responses, and also help in the decreasing the kidney progression. Whereas whenever there is a polyclonal immunotactoid or MGRS, then there is a suspicion of autoimmune diseases and infections. Next. Whether monoclonal or polyclonal, especially in immunotactoid, graft survival is very poor. Next. So this was the study which was published by Nasser et al. In Kidney International, where the studied 73 patients of immunotactoid. Almost 2/3 of the patients were having monoclonal variant. In them, 50% were having lymphoma, and 1/4 were having MGRS. And it has been shown that whenever in monoclonal patients, the clone-directed therapies were given, they had a better remission rates and less frequent ESRD as compared to the polyclonal immunotactoid gene. Next. So treatment challenges with the immunotactoid GN is next. So there is no specific established protocol treatment available for immunotactoid GN, especially in the post-transplant setting, because this disease is very rare. Next. So as Dr. Divya also highlighted, we should treat the underlying condition. If the underlying condition is hematological disorder, clone-directed therapies like rituximab chemotherapy aimed at the underlying malignancy can potentially improve the kidney disease also well. Next. And it has been shown when the clone is not identified or the proteinuria is very massive, like in this case, in that cases, the role of rituximab is not well proven, and the response rate is less, and bortezomib-based regimes have shown better results. So thank you from my side. This is one of the slides from one of our residents.
Yes, it's true. So, Dr. Radhika, from your end, any comment on histopathological side or any questions?
I already explained the things actually. It was really what do you call as our name suggests for today's topic. It's a treasure hunt. Like we started with whether it is a recurrent FSGS, and then finally ended up with this de novo immunotactoid gene. This is really very rare. And thank you for bringing up this case and sharing it with us and all the students, Dr. Kulwant sir, Dr. Divya, and Dr. Anisha. It was nice elaborative class, and
I
with
think
all
we
the
should thank you more,
differentials.
because it was more learning for us also.
Yes. And with the more differentials from both clinical aspect and pathology side also, and with the beautiful pictures shown by Dr. Anisha, and nice case description by Dr. Divya. And as the team is headed by respected Dr. Kulwant sir, we can see the results. So thank you, Arpita madam, for joining us and sharing her knowledge. And Actually, this is our last but not the least and last and best CPC webinar series of this council this year, I think, Dr. Jigar sir.
True. But I think this type of webinars in ISOT to be
Yes.
continued throughout
Yes,
because
sir. Yes, sir.
see when we were residents this type of cases weren't available even at any places, and we were thriving too much to have this type of discussion in our
Our,
institute. So
yes.
this type of things are available on YouTube channel. It will be available always, so by that way remains really useful to everyone. So the thank you, we should thank you ISOT for
Yes.
having such an initiative. So would thank you Arpita madam and Dr. Manish Balwani for same.
Yes, sir. Yeah, for the actual, thank you for ISOT for giving us this platform, Dr. Manish sir and Dr. Arpita madam. Uh, and last but not the least, our web team, like headed by Himanshu ji and Deepika for coordinating and getting us together, giving the reminders. So all the,
Thank you, ma'am.
yeah, it is like, I think I'm getting overwhelmed, sir. Better you say this
Yes.
kind of things.
Not overwhelmed, but it's a really good discussion
Yeah, it
throughout
was
today.
really nice. So today's
So
case, it's like so many differentials. Like even for two, this the look is looking like the appearance or the look you say it is those thrombi. So constantly I was thinking for cryo, and then suddenly EM comes and changes the picture. Like so, rarely in immunotactile also the thrombi are discussed. So it was nice discussion. Yes. Yes.
any take home message or closing remarks, madam, from your end or Dr. Kulwan?
Sir, as I think I closing remarks from my side is Dr. Anisha has also highlighted earlier when we were practicing, we were only sending one core for transplant biopsies just for light microscopy and C4D. And now this is a new learning. Now every institute is following this. We should send a core for IF also. And as Dr. Nisha highlighted, after 6 months of transplant period, we should always keep a low suspicion, low threshold for sending for EM also.
Sir, I would like to ask one question. Like IF also, like for after how many days post-transplant? For every post-transplant, you send the IF or like what is your practice there? Or after 6 months or a year post-transplant?
Right now, ma'am, we are sending for every biopsy, we are sending for IF also. Whether in the first few days or first initial weeks where we have a suspicion of rejection only, still we are
Hmm.
sending the biopsy sample for immunofluorescence also.
Okay.
That's nice. That's fine. Fine, sir. Yes.
So Radhika madam, from your end, the closing.
Yeah.
Um, I think Dr. Kulwant has said everything. Yes, IF core for all transplant biopsies is very important. As far as possible, we should send almost all biopsies for electron microscopy. Um, More than 6 months, definitely they should all go. And of course, there are some rare conditions. Whenever we are seeing anything like this, we must keep in mind these rare conditions and try and dig deeper wherever the LM, IF, EM are not in coordination. Maybe there is something else. So we should keep looking for more. So with that, I just want to say thank you to everybody and thank you for this opportunity.
Welcome. Yeah, all the electron dense deposit diseases, they get diagnosed even on the paraffin embedded formalin fixed blocks, except for these basement membrane diseases like thin basement membrane disease or Alport syndrome. So for that, because of the paraffin causes artificial thinning. That's what Sanjeev Sethi sir's article says. So yes, when the block is there after 6 months, if there is some suspicion of this proteinuria, hematuria, or any like duplication, if we want to see on of basement membranes, glomerular basement membrane or peritubular capillary basement membrane, so we should send it for EM definitely. Yes. Yeah, I think that's it. Dr. Divya, would you like to add something?
No, ma'am, that's all.
Okay, fine. Yes, I think we should conclude this, sir. Thank you, dear all the
Thank you.
participants, all the students, Jigar sir, for giving us this important opportunity and the time of yours, like busy schedule, all you clinicians and also the pathologists. Thank you very much. Thank you.
Mm.
And definitely we would like to collaborate in future. So let's see when we'll meet up next. And
Sure.
yeah, thank you.
So,
Bye.
Himanshu,
Bye, sir.
I think we can close. Thank you.
Yes, thank you. Thank you, Himanshuji. Thank you.
Thank you.
I'll end the session, ma'am.